Good afternoon, everybody. Thank you for joining us here at the Hypertrophic Cardiomyopathy Association's Facebook page. This broadcast will later be shared on YouTube at HCMA USA and online at 4hcm.org. Today is March 21st, 2019. It's approximately 1:05 Eastern Time, and we are going to be live here on Facebook today. So if you're watching a rebroadcast, we will comment on your questions and try to respond to your questions offline. And you're always welcome to call the HCMA office or reach us on our website. Today, we are launching a new HCMA Recognized Center of Excellence. Shortly, we will be joined by the program director from the University of Utah. First, a few housekeeping messages. The HCMA Recognized Center of Excellence structure is available for review at the HCMA website at 4hcm.org. If you have any questions, by all means, feel free to reach out to us. At the conclusion of this interview, we will open up for questions and answers. When we do open for question and answers, we do hope you understand that individual consultations will not be permitted. We will, however, address general questions about HCM, whether it be about diagnosis, management, genetic testing, lifestyle issues. We'll try to address them for you. Now, without further ado, I welcome our friend, Dr. Omar Wever-Pinzon from the University of Utah to our HCMA Center of Excellence family and here to the broadcast. Good morning.
Good morning, Lisa. Good morning, everyone. It's great to be here with you this morning. Thank you for having me.
Of course, we're excited to have you join our program as well as our HCMA family. So the first question I ask people who are in your position as directors and physicians, when was the first time you heard the term hypertrophic cardiomyopathy and what caught your interest?
Well, Lisa, so every physician in med school learns about the modern description of hypertrophic cardiomyopathy, which is typically sudden cardiac death in a young athlete, right? But my interest in hypertrophic cardiomyopathy really started about a decade ago when I did some training in cardiac imaging with Mark Sherritt, who is the director of the HCM program now in New York University, recognized Center of Excellence as well. And at that time, I learned the appropriate way that a program, an HCM program, should work, where he showed a lot of dedication to the care of his patients. There was multidisciplinary approach to the care of these patients with imaging involved, invasive cardiology involved, also surgical approach involved, and genetics, among others. So as I spent time with him, I realized that hypertrophic cardiomyopathy is a disease that is very diverse. It's very complex and diverse. So, and when I say diverse, it's at multiple levels. At the genetic level, we have discovered up to this point over 1,400 mutations involving over 13 genes, and we're still discovering every day new mutations. And every patient is different. Every patient presents with a different phenotype or the characteristics of their hypertrophic cardiomyopathy, how it manifests in the heart. They are different, and the pathophysiology as a result is different as well. So that by itself scientifically is very exciting for physicians taking care of patients with hypertrophic cardiomyopathy. So that's one of the things that really got my interest. The other point is that we have the opportunity to create an impact in these patients, right? As I said earlier, the modern description of hypertrophic cardiomyopathy is sudden cardiac death in a young patient, right? Which is the most productive part of society. So with the appropriate screening and management of these patients, we can prevent sudden cardiac death in a young individual. We can also impact families, entire families, not only the individual. Another part that is also very intriguing, very interesting about this is that as long as hypertrophic cardiomyopathy, as old as hypertrophic cardiomyopathy is, we really don't know much about it, right? This has been described over a century ago, and we're still learning every day about it, about the pathophysiology, the mechanisms underlying, and new mutations, as I said, new information, new data, and cardiac mechanics. and outcomes of these patients. So it's a very intriguing disease, and again, it's really stimulating from the scientific and clinical standpoint.
So you were in when you saw how it worked. You worked with Mark Shard when he was at St. Luke's. He's now at NYU. So you got this interesting education in an HCM center before most people even knew what an HCM center was, number one. And number two, you studied with somebody who has exquisite skills in imaging in HCM. So you learned from that. But after you spent your time with Dr. Sherrod, where else did your education take you, and where is your sweet spot in cardiology other than HCM?
Yeah, so a little bit of my background. So after I finished my training, my 2 years of training with Mark, I moved to Utah. I moved to Utah here to do a fellowship in heart failure and transplantation, and also heart failure research, and eventually end up doing general cardiology training here. And since I joined our training program here in Utah, I actually started preaching to develop a hypertrophic cardiomyopathy program and a center of excellence. I remember back in the day, there were 17 centers of excellence. I used to give talks about hypertrophic cardiomyopathy at that time, and I remember clearly that slide. We said, okay, these are the 17 centers, and I will show up a map of the United States, and we are the next center. We need a center right here in the West. So, and now we have it, and we're really proud of this. So after that training here in Utah, as I mentioned, I moved for another year of training at Columbia University Medical Center for an additional year of heart failure and transplantation. And I decided to come back to Utah. Having trained here in Utah, it gives you a good feel of what are the advantages or disadvantages of the place. And here in Utah, this is a fairly large healthcare system, which is composed of about 4 hospitals, over 12 community clinics, and we have 21 regional centers with our own insurance, which we now have probably 250,000 of patients enrolled with our insurance. And that by itself, and given the prevalence of hypertrophic cardiomyopathy, that do have big market and a lot of patients with HCM that probably had not been discovered at this point.
So Manhattan and Salt Lake, they're a little different.
They are.
But, I think that makes you quite well-rounded to understand different populations. Why don't you tell us a little bit about the rest of the team that you've assembled at the University of Utah?
Yeah, so part of the mission here at the University of Utah is to provide excellent healthcare to the patients and families, right? And we accomplish that through our mission, which is providing again excellent patient care without compromise, and not only to patients but with families when we talk about hypertrophic cardiomyopathy. We also focus on providing education, and also we get involved in research as a way to further the quality of life, the health and quality of life of our patients. So when I came here, as I mentioned, we didn't really have a structured program to take care of these patients with hypertrophic cardiomyopathy. So we started working with the support of the institution and the support of my division chief, James Fang, who since day one or day zero, he again provided his full support. And we started looking for our genetic counselor, Caitlin Swade. We also had discussions with other member teams, Dr. Stephen McKellar, who is trained in Mayo Clinic. He's the surgical director of the program. And he performed the surgical aspects of the obstructive hypertrophic form, myectomies. And we have Dr. Ben Steinberg, who is our electrophysiologist. We have also, and I'm trained in imaging and heart failure, but we have also Dr. Brent Wilson, who is more experienced in advanced imaging techniques such as cardiac MRI. So we're able to perform fibrosis quantification, better tissue characterization in these patients. We also have For instance, psychiatry involved, Dr. Troy Hoff, as you witnessed when you came to our visit. We have also maternal-fetal medicine for those patients that become pregnant, and we had to watch during their pregnancy, Dr. Amy Sullivan. And we have our dedicated APC, Holly Andrews, who with me, we are kind of the front line in the assessment of these patients. And again, we have our educators too. We have Marcy Berry, who is our clinical educator for these patients as well. We have our dietitian, Andrea Howard, and we have our collaboration with Primary Children, where the lead there is Dr. Ashwin Lau, to refer children from the affected patients and families.
You've got a big team there.
Yeah.
And I will mention that Salt Lake City specifically, it is a very unique city for HCM and for the HCMA, as we have had a relationship with Intermountain, who's the big hospital system across town. And now we have our relationship with the University of Utah. But the really interesting thing is there's one children's hospital. So no matter which center the adults go to, the children are all seen by the pediatric program there. And there's some consistency in the city and very collaborative relationships. There are some cities who have a little bit of, how should we call it, competition between medical centers. And I have found within our community in HCM, we've got a really great community that's all about putting the patient first and making sure the patient gets the right treatment and that there's access to care. And some patients may have access to one healthcare system because of their payment model and their insurance carrier, and some may have to others. And we don't feel at the HCMA that somebody should have to not have quality care because of where there happen to be insurance coverage. So in Salt Lake City, we're thrilled that we have really good choices for these patients and these families, and we can provide a very comprehensive model of care, which may end up being a beta test for programs that we're in discussions with. And you know what I'm talking about right now. So stay tuned for more information on that. So you got a great team. You've got a great infrastructure. You've got the institutional support. Tell us a little bit about your research interests.
So, as I said, one of the missions that we have here at the University of Utah is to engage in research to try to further the health and quality of life of our patients. So, we have two arms of our research projects here. One is our clinical trials, our multi-center clinical trials, and we participate in the LIFT HCM registry as well, which is the study evaluating the safety and the effects of exercise in patients with hypertrophic cardiomyopathy. We were part of that effort led by Rachel Lampert. Also, we have options for patients. We are part of the Explorer trial, which is, as you are well aware, this is a trial of mavacamten for the treatment of patients with obstructive hypertrophic cardiomyopathy. We are also in looking to not only improve the gradients, but the primary objective of this trial is to look at the improvement in functional capacity in these patients. So we're also part of the mavacamten trial, which again, this gives option to our patients. This is for the non-obstructive form of patients.
The Maverick trial.
Yeah, the Maverick. Yeah, the Maverick. Yeah, so the Maverick is for the patient with the non-obstructive form of HCM. And we're actively enrolling patients in this. And again, is to look for improvement in functional capacity in these patients. So we're really excited to offer all these options to the patients. And they're well receptive of this and very interested in what we have to offer. So I think this type of project, clinical trials, is very beneficial for patients with HCM and mostly available in Center of Excellence. So the other arm of our research is our investigator derived type of research, where we are looking at the cardiac mechanics, the effect of cardiac mechanics as evaluated with again, cardiac MRI, and to look at one of the challenges that we have in HCM, which is diagnosing HCM and trying to distinguish from other forms of hypertrophy or phenocopies of the disease. We also have engaged in clinical research looking at outcomes in patients with end-stage HCM that require heart transplantation, as we have previously discussed the findings of this study, where we're seeing that it's an increasing number of patients requiring heart transplantation within the HCM population, right? And that these patients, when they reach that stage, they're very limited in terms of their functional capacity and quality of life, which can jeopardize the outcomes after transplantation. So, and we're actually recently we have started creating a biobank where we're collecting tissue samples of all those patients that go for myectomy. And even though we're not ready to start analyzing these samples because of the numbers, we're hoping that we're gonna, with this translational research project, trying to derive some biomarkers and trying to discern a little bit better the mechanisms underlying the condition.
Wow, that's an awful lot to do. Of course, I have my personal interest in the question of transplant lately, and I have my theories, and I'd like to bounce them off of you. I think we, as a community of HCM care providers and educators and advocates, have done a better job at identifying those who are dealing with their HCM diagnosis. We are helping get them to care models that can really optimize care for a long period of time. But at a certain point, that muscle is just not going to be compliant in about, 3-4% of people. But 20 years ago, those people just did very poorly, went into heart failure and died. And others maybe were lucky enough to find themselves a transplant. As we move forward with HCM care at the highest levels, do you think our numbers of transplant might actually grow a little bit past the 3 to 5% of the population because we're managing them?
Absolutely. So everything, I 100% agree with what you said. We show this in our recent publication, Circulation Heart Failure, where we notice and we divide, our cohort of patients with HCM and 2 eras. And the early eras, we saw that these patients, as you said, 4 to 5% of the population, and these patients were coming a little bit late in the game with they developed pulmonary hypertension, and the patients that develop these features, they have increased risk after heart transplantation. And as I mentioned earlier, the number of transplants in this population increased by 44%. Now, it wasn't a straightforward path. It wasn't an easy path, and you are well aware of that probably. In order to get there, physicians probably had to jump a lot of hoops in trying to essentially request exceptions, which is not ideal, right? And this is using the old allocation system. Now, the new allocation system, it is probably not any better for an HCM population. So there's a lot of work that needs to be done there. And I know that you have been really a great advocate for this.
Dr. Barron and I helped write guidelines for listing criteria for transplant for those with HCM, but they're only like a recommendation. They're not a mandate that each program has to evaluate them. And I have found that to this day, there are still biases in certain medical institutions that went to list somebody with HCM for transplant, and we tend to get ignored until which time we become so ill that we become critical. So it's finding that sweet spot and getting us transplanted, the 4 to 5% of us. I mean, it's a small percentage, but finding that right window is becoming a challenge. Unfortunately, one of our members didn't find that window. He ended up needing heart-lung, and he never recovered. And unfortunately, he passed this week. So it's really important to time these well and make sure that we have the opportunity to have expert HCMIs working with the transplant team to say, no, this is really what needs to be done here, and that they're working in concert with each other, you and your failure team, to really understand this. And I think docs who have had a fellowship or extensive training in heart failure, advanced heart failure, and transplant, and then choose to come back to us in HCM, we're really appreciative of that, because you understand that sweet spot window, and that's going to be helpful. And the people in Salt Lake City are really, really well served in this particular small subset, because not only yourself, but the team over at Intermountain, you guys get it. And I'm waiting to see the numbers of transplant increase even more in Salt Lake, because you guys are going to be on top of this stuff. So on behalf of the patients, we're appreciative of that. So thank you.
Yeah, I totally agree, Lisa. The prior and the current allocation system are just designed for a totally different condition. And unfortunately, those patients have an advantage over patients with HCM. And finding that sweet spot is essential. Otherwise, the outcomes post-transplantation, which in general are excellent for patients with HCM. But if you wait for too long, yes, you can jeopardize those outcomes. And as a matter of fact, I forgot to mention, as part of my team, we have a dedicated transplant coordinator that helps me to work on those patients and the evaluation of those patients and trying to think about strategies, how to get that patient to the next step. Because in the way that the system works right now, those patients are allocated to the status 4, in which there's very low probability that that patient will get transplanted at that point. So we have to be very creative about ways of how to get our patients transplanted before it's too late.
The interesting thing is, and we're going off into a slight tangent on transplant immunos here, the old program, they admitted during the conference call that I was on, they admitted that there has historically been a bias against HCM patients. So they created a new system. And that new system has biases against the HCM population. And they don't understand us. The need for transplant is more than a low EF. And I think we collectively as a community need to start engaging with units in a more aggressive, nice fashion to say, you're not doing us a service. In fact, you're hurting us because we don't have any other options. We can't LVAD, we can't RVAD. Total artificials are really, really risky. We don't have any other mechanical support options. We might have some inotropes. Maybe it'll buy us a couple of weeks or months. But when it's time, it's time. The muscle's just not going to be compliant any longer, and thereby we need timely transplant. So I'm sure I can count on you to be part of our communication with UNOS to make sure that we are allocated properly. Not with benefit over anybody else, but not at the detriment of our patient population. We deserve equal footing, and we will fight for that equal footing.
Exactly. I totally agree with you. I think ejection fraction is a very crude way to assess, and I think in cardiology, or at least in heart failure, in the heart failure field, we know that that's not probably not the best way to assess function in patients. We have some other tools, but I agree with you. I think the HCM population has not seen the benefit in the wait list that other types of cardiomyopathy has seen with the increased use of mechanical circulatory support.
Absolutely. So let's talk about the logistics of getting in to see you as a patient. What does somebody do other than using the link at the HCMA website, which is on this Facebook link? But other than calling that number, what's the process going to look like? What's the timeline going to look like to get in to see you?
Yeah, so as you mentioned, you can just go to our website at the University of Utah, the HCM program, and you can have our contact. You can look at our contact information there. You can contact us through via email or phone number. So, in our HCM clinic runs 1 day per week, usually half day per week is on Wednesdays. Wednesday morning, and our volume has grown so fast that we're looking at expanding to the whole day on Wednesdays. Now, we do work with the support of the heart failure group and the heart failure clinic, and heart failure and recovery clinic runs every day. So we have no problem in seeing patients with hypertrophic cardiomyopathy when they need it. So if you call today, I can see you either today or tomorrow. So it's a process that is really expedited for my patients. Now, and something that I didn't mention earlier is that half of our patients, they come from out of state. We serve a large region, not only Utah, but from all the 6-7 states surrounding Utah. And we're used to this type of situations where we need to accommodate patients. And if patients come from out of state, we're trying to accommodate most of the testing in 1, maximum 2 days. So we can provide, good information to the patient. We can have a meaningful discussion with the patient and the family members at that time.
Fantastic.
Yeah. Now, The caveat is that HCM, and it varies patient to patient, right? And the patient that come with symptoms is probably going to require more than one visit, right? We can't just think about surgery and send the patient surgery in one day. So it's a process that, but we try to again do most of our evaluation with non-invasive testing in 1 or 2 days for those patients that come out of state. Once the patient arrives, usually this is the way that the patient presents. They arrive to me and to my clinic, and Holly Andrews and myself, we evaluate the patient. We use a comprehensive, holistic approach where we try to address the basic areas. One is the patient having symptoms or not, right? The patient is asymptomatic. Well, the patient had the complete evaluation. That patient is probably good to go for a few months or maybe a year. Now, if the patient is having symptoms, we need to get to the root of the problem. Why is the patient having symptoms? Is the patient having obstruction or not? Is the patient having diastolic dysfunction? And trying to, again, address and approach each problem. Now, the second thing that we do is trying to assess the patient risk for sudden cardiac death, which in general is not extremely high, but we know that there are individuals that are at risk for sudden cardiac death. And we look through the typical risk factors using American and European guidelines to help us to determine that risk. And in the patient that requires, implantable cardiac defibrillator, that patient will be referred to Dr. Ben Steinberg, my colleague, who is an expert at that. If the patient presents with an arrhythmia, atrial fibrillation, the patient will be referred to my colleague again, Ben Steinberg, for potential ablation procedures. We also, again, assess the genetics, right? We not only screen the patient, but also families. We have Caitlin Swade, who has been helping us for close to 2 years now with the genetic testing and coordination of the testing and the patient families for HCM. And lastly, we address the patient as a whole, right? For all the other risk factors, making sure that we are minimizing the risk for regular problems like high blood pressure, diabetes, and coronary artery disease, and the epidemic of metabolic syndrome that is affecting the United States. As part of it, it's also the recommendations about exercise, right? Because we know that patients with HCM are not immune to what the problems that I just mentioned, to obesity, hypertension, diabetes, depression, and we know that exercise, is a great benefit in all these aspects, right? So that's our approach. We're again at the front line, but once we evaluate the patient, then we'll refer to the members of the team.
Fabulous. So now I want to know a little bit about Omar. So tell us a little bit about Omar the man, not the physician. What do you do in your free time when you finally get out of the hospital and have some you time? Or is it kid time?
So in the very limited free time that I have, I enjoy spending time with my family. We go for hikes and we do sightseeing and exploring national parks, which is a lot of Utah is about outdoor activities. So that's what I do. This past winter, I started learning with my 11-year-old Leonardo to ski. So hopefully next winter I'll be doing a whole lot of more of that. And that's what I do.
I thought they kicked you out of Utah if you weren't a skier.
Yeah, that's part of the reason also that I'm starting to learn, because they did
I do have to pause here for a second and just acknowledge this, and I'm going to share this on my personal Facebook page too. My dear friend Mickey and her daughter landed in the University of Utah. Her daughter, very, very ill with a very complicated diagnosis, not having anything to do with hypertrophic cardiomyopathy. But it got really testy there for a little while. We weren't sure which way it was going to go, but the team really did help her pull through, and she has healed and bounced back and is off living her life and back to skiing at an incredibly high level, and she's doing great. And I know I called in a little favor and I said, hey, can you keep an eye on my friends while they're there? And thank you for that. And she's doing really well today. So they can speak to the quality of the inpatient nursing care and the quality of care that they receive there. And considering that they are medical professionals here in New Jersey who work at very busy hospitals, and their father does, or husband does, they were really impressed with the program. So thank you again for your assistance with my friend. So on that note, I'm going to say we are absolutely thrilled to have you on our list of HCMA recognized centers of excellence and as part of our family. I'm loving the fact that we have so many phenomenal physicians from literally all over the world, leading programs all over the United States in the treatment and management of HCM. It's only going to make our knowledge deeper, broader, and more inclusive to everybody. So thank you for joining us today. Thank you for your passion in hypertrophic cardiomyopathy. We share it here, and hopefully, ultimately, someday we'll figure out a way to beat it permanently. So thank you for your time today. And we didn't have any questions pop in, so I'm just going to kind of wrap it up because we're in the middle of the day here and everybody's still working, and they'll watch this tonight. And if you watch it later, you can post your questions below, and we will get back to you with your answers.
Well, Lisa, thank you very much for having me.
Absolutely. Have a great day, everybody. Bye-bye.
Thank you.